There was no prenatal care. There was only care for a few very rich women, only during labor. Then, in 1900, in the British Medical Journal, this Scottish obstetrician, John Valentine, wrote a paper in which he suggested that many women and babies that die, they do so with conditions that could be detected before the time of labor. And he suggested two things. First of all, that we should introduce prenatal care. And secondly, prenatal care should become universal for all pregnant women. Of course, his ideas were completely rejected by the medical establishment. But at that time, there was a group of women in England that were going around beating up the police and being very aggressive, and they were demanding the vote, because women in England in 1900 did not have the vote. This was the suffragettes movement, and as part of their campaign, they accepted and they promoted the ideas of Valentine. They wanted the vote, and they also wanted prenatal care for all women. The consequence of this action was that in 1928, the women were given the vote. The first thing that they did is that they voted for a liberal government for the first time. And one of the first actions of the new government was to introduce this report in which they suggested that we should have prenatal care for all pregnant women. And the author of the report was Arthur Greenwood, who was the Minister of Health at that time. And Arthur Greenwood, this lawyer, not only suggested that all women should have prenatal care, but he produced a scheme, a pyramid of care, in which he suggested that all women should be seen at 16 weeks, and then every 4 weeks until 28, then every 2 weeks until 36, and then every 1 week until delivery. I am sure that in Brazil and in Latin America, as in the United States and in England and all other countries in the world, they are following this traditional pyramid of care introduced by this nice-looking English lawyer in 1929. And it was a major advance at the time because it was much better than nothing. But the basis of this care had two characteristics. First one, that the problems of pregnancy must happen at the end. That is why you must see women a lot at the end. And secondly, nothing is really predictable in the beginning, therefore there is no reason to see women early in pregnancy. And the question is whether this pyramid of care that has been practiced for the last 80 years throughout the world is still relevant in modern obstetrics. I believe that a lot of the problems are being predicted and potentially prevented, and they can be seen or can be identified from the beginning of the pregnancy. If this was true, we will see a complete change in our thinking. Not a pyramid which aims to identify problems when they occur and then try to deal with them, but a new approach in which we try to predict these problems early in pregnancy, and on the basis of this prediction, we'll provide a rational, individualized antenatal care based on the individual woman risk for the individual condition. If this was true, then we would be dividing the women starting from 12 weeks into a low-risk group, perhaps the majority, perhaps 90%, that will follow a reduction in the total number of visits. The next visit will be at 22 weeks, and the next one at around 32 or 36 weeks. Therefore, few women that will still be pregnant can see them at 41 weeks. On the other hand, the group of women that have been identified as being at high risk of preeclampsia or premature delivery or fetal abnormalities should be seen in specialist clinics. Therefore, they will receive better care, and hopefully there will be an overall reduction in cost, because the majority of women will not need to have so many unnecessary visits, and the few that have problems will be seen by experts. Let me now discuss the concept a little bit further. If we can look back at this great philosopher, Galileo Galilei, he suggested 500 years ago that in science, in life, in all fields, we should be thinking along three basic principles. That the language of God is mathematics. He said that we must try to convert everything that is possible to convert into a mathematical formula, because if we have a mathematical formula to underpin every action that we undertake, we will be able to communicate better, and we will have a scientific basis for our actions. He suggested that we must challenge the old, not in a disrespectful way, but with the intention of improving the past with something better for the future. He suggested that we should measure everything that is possible, and we should make measurable even things that we think may not be easily measurable. If this concept is converted into a mathematical formula, the mathematical formula would look something like this. We ask, first of all, which is the condition that we are screening for. Let's say that we are screening for Down syndrome. The risk for each woman for Down syndrome is based on her prior risk, which is derived from maternal age, and then the prior risk is multiplied by the likelihood ratio of a series of biochemical and biophysical tests, so that we can derive the individual personalized a posteriori risk. So, what is your risk for Down syndrome? Based on how old you are, and the results of 3-beta HCG, and the results of PAVE, and the results of nuchal translucency, to combine into this mathematical formula. The same principle can be applied for other conditions. What is your risk for premature delivery? It depends on your age, your race, your weight, whether you smoke or not, whether you had a previous premature delivery or not, multiplied by the results of the measurement of the cervical length, and multiplied by the results of, for example, fetal fibronectin, or in the first trimester, alpha fetoprotein. What is the individual woman risk for preeclampsia and fetal growth restriction? Depends on how old she is, depends on what is her weight, whether she smokes or not, whether her mother had preeclampsia, whether she suffers from chronic hypertension or systemic lupus erythematosus. Depends on how she got pregnant, by IVF or naturally. Depends on whether she had preeclampsia in her previous pregnancy. This information is then combined and multiplied by the results of the uterine artery pulsatility index, and the measurement of the mean arterial pressure, and the measurement of placental growth factor or other biophysical and biochemical tests. So with this approach, which is similar, we are converting an idea into a mathematical formula which is measurable, and we are carrying out a series of investigations in a rational way that carry a value, carry a risk factor, carry a likelihood ratio, either to increase or to decrease the prior risk. These tests can be carried out in the same visit, let's say at 12 weeks, Or some of the tests may be carried out later on in pregnancy. So you start off with one risk, and on the basis of the subsequent investigations, that risk is modified. It is either increased or it is decreased. Let me now proceed to illustrate how this new concept would work. The first question that I will ask is, can we really invert the pyramid of care? Are there realistic prospects that we will be predicting, diagnosing the vast majority of pregnancy complications from the beginning? The first condition that has been investigated successfully is that of Down syndrome and other chromosomal abnormalities. Over a period of now 40 years, the mathematical formula is finding an expression in asking women, how old are you? The 1970s test. The older you are, the greater is the risk that you will have a baby with Down syndrome. If you are over the age of 35 and you do an amniocentesis for all of these women, you will detect 30% of the babies with Down syndrome. And then in the 1990s, we described how in a lot of babies with Down syndrome, the measurement at 12 weeks of nuchal translucency thickness is increased. And when we combine maternal age with nuchal translucency thickness, we can now identify 80% of the fetuses with Downs. By 1998, we realized that in pregnancies with Down syndrome, the maternal serum free beta HCG is increased and the maternal serum Pab is decreased compared to chromosomally normal pregnancies. If we then combine maternal age, nuchal translucency, free beta HCG, and Pab, at 12 weeks, we can now identify 90% of the fetuses with Down syndrome. So we have seen an evolution from age into the combination with ultrasound and biochemistry at 12 weeks to improve the performance of screening for Downs from 30 to 90%. And then in the last 10 years, we have been looking at additional biophysical markers. We realized that in babies with Down syndrome, the nasal bone is often absent. We looked at the fetal heart across the tricuspid valve, and this is a normal waveform. And in a lot of babies with Downs, this tricuspid regurgitation. We looked at the ductus venosus, and this is the normal waveform. We realized that a lot of babies with Down syndrome have abnormal flow in the ductus venosus with absent or reversed A wave and a solid flow. More recently, we realized that the same examination is for the ductus. Next to it, we can see the hepatic artery, and that in pregnancies with Down syndrome, the blood flow in the hepatic artery, the blood supply to the liver is increased. When we now combine these new biophysical markers, the detection rate is improved to about 98%, and we have a simultaneous reduction in the false positive rate in the number of invasive tests from 5 to less than 3%. More recently, we also discovered that in pregnancies with Down syndrome, another biochemical marker, placental growth factor, is reduced. We also realized that some of the biochemical markers of Down syndrome are also biochemical markers of preeclampsia, because Pab and PLGF are reduced not only in pregnancies with Downs, but they're also reduced in pregnancies with subsequent development of preeclampsia. So, in asking the question, can we really invert the pyramid of care in the context of chromosomal abnormalities? The answer is yes, we have already done so. And in many, many countries of the world,
Not us. It's London.
Yeah.
It's London.
You can see obstructive neuropathy and megacystis. You can see this completely distorted body in a fetus with the body stalk anomaly. All of these conditions that can easily be seen at 12 weeks constitute about 1/3 of all the major fetal abnormalities. The next question was, can we diagnose some more defects like spina bifida? In the 80s, the method of screening for spina bifida was to measure the maternal serum protein at 16 weeks. And in about 75% of the babies with spina bifida, the maternal serum protein was increased. In 1986, I realized that it is not necessary to measure maternal serum protein at 16 weeks because with a simple ultrasound examination of the head, you can see that the shape of the head in babies with spina bifida is abnormal. This is the normal shape, and in babies with spina bifida, we have this lemon shape of the head, and at the other end of the body, at the back of the brain, we have this banana-shaped cerebellum. And this could now identify 98% of the cases of open spina bifida without the need to do alpha-fetoprotein screening and amniocentesis to measure acetylcholinesterase. In most countries of the world, the last few decades, people have abandoned the second trimester serum alpha-fetoprotein. The problem is that when we moved to the first trimester, the lemon and the banana shapes were not easily visible at 12 weeks. However, recently we realized that in the same mid-sagittal view of the fetal face, as for the measurement of nuchal translucency and the examination of the nasal bone, if we look inside the brain, we can see the midbrain, the brainstem, the fourth ventricle, and the cisterna magna. And in cases of open spina bifida, there is leakage of cerebrospinal fluid, and the brain is pulled down. And as the brain is pulled down, the brainstem becomes fatter because the midbrain goes down. And if this becomes fatter, that is being done at the expense of the fourth ventricle and cisterna magna. So in cases of spina bifida, here is the brainstem, which becomes bigger. The red dots are babies with spina bifida, and the combination of the fourth ventricle and the cisterna magna is compressed and it is small. Now, I believe we can diagnose the vast majority of babies with open spina bifida in the 12th week of pregnancy from this very basic examination in the same view for the measurement of nuchal translucency. More recently, we discovered that in cases of spina bifida, of course, the brainstem is increased and the fourth ventricle cisterna magna is compressed. But the opposite is true in cases of the Dandy-Walker malformation, where the brainstem is compressed, but the fourth ventricle is already visibly increased from the 12th week of pregnancy. The number of conditions that we can diagnose will increase. The biggest challenge, of course, in fetal medicine is the prenatal diagnosis of heart abnormalities. The traditional approach for the diagnosis of heart abnormalities is to send women at high risk to experts. It was realized that the heart is very small, especially at 12 weeks. This is the relative size of the heart at 12 compared to 20 weeks. we realized that in babies with heart abnormalities, if you have an expert that specializes in examining the heart, you can relatively easily diagnose the heart abnormality even at 12 weeks. But for the rest of the blood medicine specialists, examination of the heart was a difficult topic. So the main challenge from my point of view was to define a better screening test to identify the women that would be referred to the specialists, because if they go to the specialist, they can diagnose these abnormalities. The traditional way of identifying the high-risk group, referral, was to take a maternal history. If a woman had a baby with a heart abnormality or two, or if she had a heart abnormality herself, the risk was increased. If she had diabetes, or she was depressed on lithium, or she was taking anti-epileptics. The problem is that if we refer all of these patients to a specialist, we will only diagnose 10% of the cardiac defects because 90% of the babies with heart abnormalities will come from women that do not have this high risk profile. In the last 10 years, we realized that the same ultrasound markers of Down syndrome can be used as markers of screening for heart abnormalities. We realized that the higher the nuchal translucency, the black line here, the greater is the risk that the baby will have a heart abnormality. And if the blood flow in the ductus or the tricuspid are abnormal, the risk is increased further. So that now, if we have, in addition to history of diabetes and depression and so on, if we incorporate in the method of screening for heart abnormalities, nuchal translucency and ductus venosus and tricuspid flow can now increase.
London. London. Internet muito ruim.
We need to find a good method of preventing prematurity in the higher risk group. We know that if we ask some basic questions, the risk of premature delivery is increased if the woman is short. It is higher if she is black, if she smokes, if she conceived by IVF or the use of ovulation drugs. It is much higher if she had a previous premature delivery or two, and the risk is less if she had a previous term delivery. If we combine these basic pictures in the mother's history into a mathematical formula to calculate an individual risk for premature delivery, we can identify 1/3 of the premature delivery groups. And then, if we also measure at 12 weeks the cervical length, transvaginal scan, can see the endocervix, can see the glandular epithelium around the endocervix, and if we measure the endocervical canal, pregnancies that will deliver prematurely, this tends to be in the low range of the normal reference range. So in women that will deliver prematurely, the cervical length at 12 weeks is shorter than in the women that will deliver at term. And then we realized that in some of the women will deliver prematurely, maternal serum alpha-fetoprotein at 12 weeks is increased. If we combine history, measurement of cervical length, and alpha-fetoprotein at 12 weeks, we can identify now from the beginning of the pregnancy 60% of the women that are destined to deliver prematurely before 34 weeks. The next question is, can we actually do something to prevent premature delivery in the high-risk group? And the answer is yes. There is now good evidence that if we give progesterone, this is a study that we carried out in England, basically, and we gave progesterone to women starting from 24 weeks, vaginally every night from 24 to 34 weeks, if they had a short cervix, and we found that there was a 44 reduction in the rate of spontaneous delivery before 34 weeks. And last year, the group of Roberto Romero in the United States carried out a very similar study. They found exactly the same results. So here we are. If we take women that have a higher risk of premature delivery, and we give them progesterone, we can reduce the risk by nearly 50%. I believe that if we start giving the progesterone from 12 rather than 2 weeks, it is likely that this may be even more effective. In any case, can we identify the high-risk group at 12 weeks? Yes, we can identify a high proportion of women that are destined to have spontaneous premature delivery. Can we do something about it? Yes, we can. We can give them progesterone. Is progesterone expensive? No, it is cheap. Is progesterone dangerous? No, it is safe. So, why not? The next question was whether at 12 weeks we can identify the high-risk group for preeclampsia. And in defining, however, preeclampsia, in contrast to defining Down syndrome, where you either have Down syndrome or you don't, in the case of preeclampsia, we recognize that we have a heterogeneous condition which has completely different consequences if you develop preeclampsia at 40 versus 24 weeks. We have known for many years that the underlying pathology for many cases of preeclampsia is impaired trophoblastic invasion of the maternal spiral arteries. But this is mainly true, this abnormal presentation, for early, not for late preeclampsia. We have known that preeclampsia is often associated with fetal growth restriction. This is very true for early preeclampsia, not for late preeclampsia. Known that preeclampsia is associated with an increased risk of perinatal death, and the rate of perinatal death is inversely proportional to the gestational age at which you develop preeclampsia, and not only perinatal but also maternal death is much higher if you have early than if you have late preeclampsia. In order to capture these differences in the implications and pathophysiology of preeclampsia, depending on the gestation at which you develop this condition, my good friend, a mathematician, David Wright, developed an algorithm where he suggested that all women, if they were allowed to be pregnant indefinitely, will develop preeclampsia on average at 55 weeks of pregnancy. And therefore, there is a competition between developing preeclampsia before you deliver or delivering so that you do not develop preeclampsia. And he suggested that we have this normal distribution of risk to develop preeclampsia and the low-risk group to develop preeclampsia on average of 55 weeks. So very few will develop preeclampsia before actually 40 weeks. But if we have a high risk for preeclampsia, there is a shift of this graph towards the left so that more women develop preeclampsia before delivery. Which are these risk factors of developing preeclampsia? The higher the maternal age, the higher the maternal weight. If you are Black and South Asian, Pakistani, Indian, Bangladeshi, if you had a previous pregnancy with preeclampsia, if your mother had preeclampsia, if you conceived by IVF, or you started your pregnancy with chronic hypertension, diabetes type 1, and systemic lupus erythematosus, the risk was increased, so there was a shift to the left of developing preeclampsia. And then we moved on, and we looked at a series of biophysical markers. We measured at 12 weeks the uterine artery pulsability index. We do an ultrasound scan transabdominally. We look at the cervix, and we put a color Doppler on, and on either side of the cervix, we can see the uterine arteries. We measure the pulsability index, and we discover that in pregnancies that will develop preeclampsia, the pulsability index increased, especially in those that will develop early than late preeclampsia. So we can now identify by a combination of history and uterine artery Doppler at 12 weeks, around 75% of the women that will develop severe early onset preeclampsia requiring delivery before 34 weeks. We then started measuring the mean arterial pressure using automated machines and the methodology in which women rest for a few minutes, and then we measure the blood pressure simultaneously in both arms, and we take two measurements of the mean arterial pressure from the right and two from the left, and we take the average of these four measurements. We found that at 12 weeks, the mean arterial pressure of women that will develop preeclampsia is increased. We also measure maternal serum, PAP-A, and placental growth factor, and the values in those that will develop early but not late preeclampsia are increased. And when you combine all of this history with the biophysical and the biochemical results, we can identify at 12 weeks in pregnancy about 95% of women that are destined to develop preeclampsia requiring delivery before 34 weeks. And you could argue, but what is the point of knowing at 12 weeks that a woman will develop preeclampsia at 33 weeks? Will we not worry these women unnecessarily? The answer is very, very simple. There is some evidence that the use of low-dose aspirin can reduce the rate of preeclampsia by about 10%. And when you look at the studies on when they started giving the aspirin, the rate of drop in preeclampsia was 50% if you started giving aspirin before rather than after 16 weeks. And this is particularly important because early administration of aspirin is particularly effective, 90% reduction in premature preeclampsia than term preeclampsia, and a major reduction also in perinatal death. So it is important to identify the high-risk group early because we believe there is an effective intervention could potentially reduce the prevalence of the disease. This data comes from a meta-analysis of a few existing randomized studies. I believe that these results are very encouraging, but it is important to confirm whether this is true in a major randomized study, and this is what is being planned to start very soon in other countries in Latin America. If you want, we can discuss that further. And then I asked the question about fetal growth restriction in the absence of preeclampsia, and again, the same characteristics, history factors, uterine artery Doppler, mean arterial pressure, can identify the high proportion of the patients at high risk of delivering small for gestational age babies in the absence of preeclampsia. And then we developed a mathematical formula that combines the risk of preeclampsia and the risk of fetal growth restriction, and the combination formula can identify more than 95% of the women that will develop preeclampsia and more than 50% of the women that will deliver small for gestational age babies in the absence of preeclampsia. Therefore, already the new software of the Fetal Medicine Foundation that we released, they told me now in October, I hope that is true, will be asking the women a few basic questions at 12 weeks in their history. We will be measuring the neutral translucency and uterine artery pulsatility index, the mean arterial pressure, and cervical length, and we will be measuring libido HCG and PAVE and PLGF and AFP, and the computer will be giving you a risk of preeclampsia, trisomy 21, 18, premature delivery, fetal growth restriction in the absence of preeclampsia. So we already have a methodology for the early prediction of not only Downs but many pregnancy complications. And the same is true for stillbirth. And here, early prediction is particularly effective for early stillbirth, where the underlying pathology is impaired presentation, and the babies are often very small, whereas with late stillbirth, about 1/3 of the stillbirths are in association with placental insufficiency. The other 2/3 are in babies that are normal size or even big babies. Finally, conditions like gestational diabetes, where a combination of maternal history and the measurement of maternal serum adiponectin and sex hormone binding globulin can identify in the 12th week of pregnancy about 75% of the women that will develop gestational diabetes. Bigger problem that is becoming major issue throughout the world is the problem of obesity, because the higher the body mass index at 12 weeks, the greater is the risk of miscarriage and stillbirth and preeclampsia and diabetes and macrostomia and the need for cesarean section. The question really is, how do you address this issue? And one option is by pharmacological interventions, like the prophylactic use of drugs like metformin that will reduce the appetite of these women. They will eat less, they will gain less weight. Hopefully, that will reduce the prevalence of preeclampsia and diabetes and macrosomia. Finally, the pyramid of care is already inverted in the context of a twin pregnancy, where at 12 weeks we can effectively distinguish between monochorionic and dichorionic twins, and this is the biggest discriminant of pregnancy complications, because if the pregnancy is monochorionic, the rate of miscarriage and perinatal death and fetal growth restriction and premature delivery and the delivery of an abnormal baby is much higher in monochorionic than in dichorionic twins. We know that the most problematic complication underlining a lot of these problems is selective fetal growth restriction, found in about 10% of cases, and development of severe twin transfusion. And for both of these conditions, we do have a relatively good method of intervention in the form of endoscopic laser surgery to separate the communicating placental vessels. The pyramid of care suggested by a minister of health in England in 1929 has been useful for 80 years. However, I think the time has changed, and many of the pregnancy problems that we had to wait until the end of the pregnancy to identify, we can now predict in the beginning of the pregnancy. And I've shown you that we can identify the vast majority of chromosomal abnormalities, and we can identify a lot of the major phenotypes. We identify a high-risk group for premature delivery, and there is the potential of reducing the rate of prematurity by the administration of progesterone. Shown you that we can identify a high-risk group for fetal growth restriction, preeclampsia, and stillbirth, and potentially we can reduce these complications by the early administration of aspirin. Shown you that we can identify the high-risk group for macrosomia and gestational diabetes, and we have to develop a strategy of reducing these complications by pharmacological interventions like metformin. We identify the high-risk group for complications in multiple pregnancies, and we can treat these patients well with endoscopic laser surgery. I feel that the time has come in the evolution of antenatal care to begin to think of inverting the pyramid of care. So thank you very much. Thank you.
Say something.
Thank you, Kypros. We have a few friends of yours here. Jadis, first one.
Hello, Prof. How are you? Come to the.
Thank you. Hi.
Hi. Go ahead. Say hello. Can I have some questions?
Yes. No, direto. Pode falar.
Just talk.
Prof, we have some questions for you from the audience. Is that okay?
Yes, of course.
Perguntas?
The first question, Prof, is that which would be the patients that when using the screening for preeclampsia, which would be the patients that would have the most use of aspirin, Prof, from when like?
I think that when people are conducting studies, you can look at individual high-risk pregnancies. You can look at only nulliparous women, or you can look at women that had a previous case of preeclampsia, or women that have chronic hypertension, or systemic lupus erythematosus, or diabetes. But I think in a screening program, you look at everybody, because a lot of the women that are in their that have had previous pregnancies, even if they do not develop preeclampsia, they may develop preeclampsia in this pregnancy. So I think that in the same way as in the past, we used to think of high-risk woman or Down syndrome, a woman that was 40 years old, and then we realized that it is true that a woman that is 20 years old has a much lower risk, but in reality, if we ignore the so-called low-risk groups, we will miss the majority of the cases of preeclampsia. So, in developing a national screening program, we should include everybody, and then the mathematical formula will combine the individual patient characteristics with the findings from 12 weeks, the Doppler and the arterial pressure and the PLGF to identify and truly classify a woman as being at high risk or low risk. So I think that this approach should be applied to everybody.
Prof, a second question is, can you please comment on the use of heparin and preeclampsia?
Yes. I think that in the case of a subgroup of patients, those with systemic lupus erythematosus, the Arthur-Vivid syndrome, there is a lot of interest and there is some evidence that heparin will be useful. In terms of the case of preeclampsia in the absence of systemic lupus erythematosus or phospholipid syndrome. The evidence is not available that this would be useful. However, I know that in Spain, at the moment, they are conducting a randomized study to see whether heparin, in addition to aspirin, would be useful in this high-risk group. So I think we will have to really wait for the results of that study before we start giving heparin to people. There's a big difference between giving just aspirin, which is cheap, easy to administer, and moving into asking the women to have injections every day of heparin. We have to wait for the results of these randomized studies to see if it is useful or not.
Any more questions?
¿Alguien tiene alguna pregunta?
Nada más que el grupo de ellos, en relación a las dosis que siguen manejando y las dosis bajas de aspirina, y el otro grupo que está en relación a la resistencia y que
Repíteme otra vez. Dímelo otra vez. I'm getting the question from the audience, Prof. Just give me just one
That's
second.
el grupo de ellos siguen manejando la dosis baja. O sea, ¿qué experiencias tienen manejando o ya lo están haciendo en relación a la dosis que se maneja por encima de 16, de 160 miligramos que están manejando los otros grupos?
Okay, see if I get this correctly. You have been managing or have experience with the low dose, which is a 75 milligram dose in the UK. Do you have any experience with any groups or within FMF of the higher dosing aspirin for use?
When we a few years ago, we conducted a randomized study at 22 weeks when we did second trimester uterine Doppler, and we randomized the women into aspirin. And in that study, we used 150 milligrams of aspirin because we know that a few women, and when I say a few, I mean 30%, so it's not a few, it's quite a lot, may be insensitive to the very low dose of 75 milligrams. So we wanted to check whether, if we are going to test aspirin, we might as well give a proper dose, 150 milligrams. We were worried at that time as to whether that would increase bleeding, abruptions, and even gastrointestinal problems. The answer is that there was no evidence that a higher dose, 150 milligrams, had any major side effects. So I think that if we are going to conduct a first trimester study for the same reason, this high percentage of women that may be insensitive to the very low dose, it should be 150 milligrams, and from the literature, there is no evidence that this would increase the rate of complications like hemorrhage and abruption.
That's it. Go ahead.
Kypros, thank you very much, and we appreciate your time, and good to see you again. Hope we see you at the end of the year in London, and we are moving forward here with the pre-eclampsia trial. We'll receive news very, very soon.
Thank you very much, and I wish you all success, and thank you for listening. Thank you.
Thank you.